afternoon, student. So, due to the network problem, we will delayed for our lecture today. So, we was learn in the last week about the general principles of fractures and dislocation. In that, we was learn about its introduction, definition, types of the fractures, approach to orthopedic injury, investigation to orthotrauma, management of fractures, open fractures, approach to compound fractures, and approach to a polytrauma case and a dislocation. So, when we was learn about the introduction definitions of about fractures, dislocation, subluxation, sprain, and strain. That is, fracture is a break of any surface of the bone, either across its cortex or through its artificial surface. And dislocation is a complete and persistent dislocation of a joint. Then subluxation is a partial dislocation of a joint, and sprain is a temporary subluxation, that is temporary dislocation of a joint due to the ligament injury and the articular surfaces return to normal environment. Then strain is a tear in the muscle. So remember, forces required to break a bone could be large and sudden. For example, in RTA, that is road traffic accident, repetitive, that is example is stress fracture, trivial, that is pathological fracture. So, in that we was learn about the types of the fracture, that is simple or compound, and it is based on the extent of the fracture line, that is incomplete and complete fracture. And the complete fracture could be undisplaced or displaced. So this is a diagram of a simple fracture, and this is a compound fracture. In that the two bones are involved, and in that simple fracture is the only one bone involvement is shown. Then, based on the fracture pattern, there are the classification of fracture, that is linear fracture, comminuted fracture, segmental fracture, and the bone loss. Linear fracture could be transverse, oblique, spiral, and fracture that form on angle less than 30 degree with the horizontal line is transverse, and angle is equal to more than 30 degree is termed to be oblique. Comminuted fracture is that here the fracture segments are more than 2 in number, and they are further subclassified into the less than 50% or is equal to 50% combination or more than 50% combination. So there is a butterfly shape fracture also present, and segmental fracture can be break into the segment, and the segment could be 2 level, 3 level, and a longitudinal split or comminuted. And in the bone loss, this could be less than 50% bone loss, more than 50% bone loss, or a complete bone loss. So, in the diagram of the type of the fracture, which is based on the fracture part pattern, is that it was learned about that this is a transverse fracture in that the bone is fractured transversely. Then this is a spiral fracture in that bone is fractured spirally. This is an oblique fracture in that bone is fractured obliquely. And this is a comminutal fracture that fracture fragments are more than two in number. In that we can see fracture segment is more than two in number, and they are further subclassified into 50% combination or more than 50% combination. Then this is the last one is segmental fracture. In that we can see how the bone is divided into 2 to 3 segments. Then the other types of the fracture, that is atypical fracture. In that we was learn about the green stick fracture. It is exclusively seen in children, and here the bone is elastic and usually bent due to the buckling or breaking in one cortex when a force is applied. So this is called as a green stick fracture. Then impacted fracture. Here the fracture segments are impacted into each other and are not separated and displaced. Then a stress or a fatigue fracture is usually an incomplete fracture commonly seen in athletes and in bone that is subjected to the chronic and repetitive stress. For example, a third metatarsal fracture or the fracture tibia. Then fourth is a pathological fracture. It occurs in a diseased bone and is usually a spontaneous. The force required to bring about a pathological fracture is a trivial. The hairline or crack fracture, it is a very fine break in the bone that is difficult to diagnose clinically, radiologically, and usually help or still better in a CT scan. Then a torsus fracture. This is just a buckling of the outer cortex. So in the diagram of the atypical fracture, we was learned that is how there is a compression can occur. So there is a compression in this region, that is lumbar region. This is the pathological fracture is present due to the pathological any disease is before uh, means that there is some pathological condition is already present in a patient in which lead to the breakage of the bone, so it's called as a pathological. This is a green stick fracture in that we can see that how there is a bending of the bone in the children, that is a buckling due to the external pressure, and a torsus fracture. Hmm? The torsus fracture is also buckling of the outer cortex. So remember, the green stick fracture occurs in the children, stress fracture common in athletes, fatigue fracture in occupation like police, nurse, etc., and pathological fracture that is usually seen in the elderly people, hairline fracture or the crack fracture is a special variety of incomplete fracture. Then a displacement of a fracture. A complete fracture usually gets displaced due to the various factors and depending on the direction of the force, mode of the injury, pull of the muscles, a fracture can show any one of the following displacement or angulation. So there is an anterior angulation, posterior angulation, varus or medial angulation, valgus or lateral displacement or angulation, shortening and transition. These are the types. So when we see a diagram of the types of the angulation in fracture, we can see how this fracture bone is displaced medially. So this is a medial angulation. Then in that B diagram, we can see how the fracture bone displays laterally. In the diagram C, we can see that how the fractured bone is displaced anteriorly, and this is a posterior angulation where fractured bone displaced posteriorly. So this is the types of the ambulation in fracture. Then approach to orthopedic injury. So orthopedic injury encompasses a wide range of the problems starting from bone and joint injuries, strain, sprain, and damage to associated neurovascular structure. So, the value of the systemic clinical approach to unravel the might and mysteries that time honored and time tested clinical formulae applied so successfully in the diagnosis of the various systems disorder can be applied for orthotrauma also, and consist of the following, that is firstly the history. So when the patient come in our clinic, so history is the more important in the case of the orthopedic injury. That is, contrary to popular belief, a proper history gives a vital clues and goes a long way in arriving at a proper diagnosis. Then second is age. The certain fractures have predilection age group, hence the practice of first inquiring about the age of the patient is a step in right direction. Then the sixth, that is Colles fracture is more common in the female, and the supracondylar fracture of the humerus, posterior dislocation of the elbow are more common in males. Then relationship of the age and fractures, that is in age, firstly there is the fractures and dislocation, then birth. So there is a brachial plexus injury, fractures clavicle, fracture humerus, etc. Then early childhood, in that supracondylar fracture of the humerus, epiphyseal injuries. In the late childhood, there is a posterior dislocation of the elbow with the slip capital femoral epiphysis and Monteggia fractures. And in adulthood, there is a fracture of the long bone, hip and shoulder dislocation. So in elderly people, there is a Colles fracture and fracture neck femur. In spite of the age of the predilection, any fracture can be seen in the any age group as an fracture. So the relationship of the age and types of the fracture and the mode of the injuries, in that firstly age, common mode and examples of the injury. So in the children, when they fall out, there is a fracture of the clavicle, which had fracture are usually while or play dislocation on any or form height upper limb bones. And in adult, when they fall from the height, there is a upper limb injury, spine injury, diving injury, that is the cervical spine injury is seen. In RTA, that is in road traffic accident, for example, any combination of the injury, whiplash injury, dashboard injury, like a fracture patella, posterior hip dislocation, etc., can be seen. Sports injury, for example, ankle and shoulder, that is maybe there is elbow and knee joint injury, assault, for example, a long bone fracture. For example, there is a nice stick fracture of the ulna, and in elderly there is a trivial fall. For example, Colles fracture and fracture neck, femur, etc. are seen. So, the high velocity trauma due to RTA can produce any combination of the bone and joint injuries. So clinical feature in that we can see there is a pain, swelling, deformity, inability, tenderness, swelling, deformity, abnormal mobility is seen. So there is some important deformities in orthopedic, that is the Diener fork deformity. This is then Schwann neck deformity. This is the anterior dislocation of the hip, and this is the posterior dislocation of the hip. So these are some deformity facts that we was learned in a previous lecture. Then there is the loss of transmitted movement, crepitus, shortening is seen. So clinical manifestation in the fracture are due to fracture per se, then its complication or so tenderness. In the tenderness, remember that may be only evidence of fracture in crack fracture, hairline fracture, stress fracture, fatigue, torsus, and the pathological fracture shows a tenderness. So the method of eliciting proceed from normal area to the affected part for the better patient compliance. In that grade 1 is just a suspect, then grade 2 that patient winces on pressure, grade 3 that patient winces and withdraw, and grade 4 that patient will not allow to touch. This grading of tenderness is superior to conventional mild, moderate and severe grading. Then, crepitus is defined as an abnormal grating sensation, either felt or heard, that could be a fine in or osteoarthritis, that is OA, a coarse when there is a fracture, and snap when there is a snapping tendon. So, fine crepitus seen in OA, coarse crepitus seen in fractures, snap crepitus seen in a snapping tendon. Remember, it is unkind to elicit a crepitus in a fracture for a fear of hurting a patient. Then, deformity is defined as a deviation of the normal anatomy of a bone or joint. Remember, D in fracture, that is, deformity is seen often in a displaced fracture. Displacement could be anterior, posterior, medial, or lateral. Then, distal fragment is the circumference is the reference point to suggest the type of displacement. Then the dislocation of the joints usually present a deform. Then interesting features about the clinical signs in that various clinical signs are described in fracture. They can be best represented as follows in order of their importance, in that there is a clinical manifestations due to the neurovascular injury. Certain fractures are known to cause a neurovascular damage quite frequently. For example, supracondylar fractures of the humerus inguinal and the familiar 5 Ps detect the impending vascular damage, and the nerve injuries are detected by the classical deformity and screening test. So, as described in peripheral nerve injury. So, prevalence of the clinical sign, that is, unfailing sign is the abnormal mobility and capital. Reliable sign is tenderness and shortness. Important signs is bruise and swelling. Other signs are loss of functions and deformity. The late or inconstant signs are blisters, ecchymosis, and swelling due to the case. Then about the 5 Ps, that is, in detecting impending vascular damage in musculoskeletal trauma, that is pain, pallor, paresthesia, pulselessness, and paralysis. So there are certain bones in the body, the fractures of which are usually missed in the initial examination. These are known to cause diagnostic difficulties and diagnosis. So the missing facts in the fracture are zygoma, base of skull, odontoid process, C7 vertebra, then ribs, radial head, impacted fracture neck of the femur, undisplaced pelvic fracture, scaphoid fracture, carpal dislocations, then tarso-metatarsal joints, talus fracture, march fracture, and among these, scaphoid is top the list. So, certain bones in the body, the fractures are usually missed in the initial examination. In that, scaphoid is the topmost, and these are known to cause a diagnostic difficulties and dilemmas. Then, investigation to in orthotrauma, that is radiography. It is an important diagnostic tool for the fracture, that is minimum two views, that is anterior and posterior and lateral, are required as a bone isocylinder. Sometimes an oblique view and other special views are required depending upon the clinical situations and bone under the study. Then, a vital fact about the plain X-ray is that radiological clues one should look for on plain X-ray for diagnosis of a fracture, then situation whether it is in the diaphysis, metaphysis, epiphysis, and the articular surface. In that anatomy, that is look for the fracture line, whether it is a transverse, oblique, spiral, segmental, and comminuted, etc. Also look for the alignment, angulation, displacement, rotation, etc. Then number that how many fragments are seen in that bone condition. Identify whether the bone is normal or pathological. Then joint involvement, that is look for the extension of the fracture. So then there is a plain X-ray. Radiological clue one should look for the plain X-ray for diagnosis of the fracture. In that situation, then anatomy, then alignment, angulation, displacement, rotation, then the number, that is how many fragments are seen in a fracture, bone condition, whether it is bone is normal or pathological, and joint involvement, that is the look for extension of fracture. That fracture extended how much is very important. Then lines into the joint swelling, and for evidence of dislocation is also important with the soft tissue swelling. The extent of soft tissue swelling indicate the severity of the injury. So, soft tissue swelling is also important sign which indicate the severity of the injury. Then, a pitfall of X-ray. Presence of a fracture line on X-ray help confirm the diagnosis, but its absence does not rule out a fracture. Hairline fracture tend to be missed. For example, scaphoid fracture. Then some dislocation, if associated with fractures, could be missed. For example, Montague fracture. In comminuted fractures, the number of fragments could be misleading. Be aware of artifacts, they could mislead you. Be careful in interpreting the fractures like appearances, for example, apophysis, and avoid interpreting a low quality X-ray. So, X-ray is helpful for the diagnosis of the fracture, but its absence does not rule out a fracture. So, hairline fracture tend to be missed, like scaphoid fracture, and some dislocation, if associated with the fracture, could be missed. And in comminuted fracture, the number of fragments could be misleading. Be aware of artifacts they could mislead you, and be careful in interpreting fractures like appearances or apophysis, and avoid interpreting a low quality X-ray. Then role of the X-ray. So what is the role of the X-ray in fracture is that X-ray helps to confirm the clinical diagnosis. It helps the study of the fracture anatomy. Then X-ray helps the study the fracture displacement. It helps to detect crack and stress fractures and help to plan the treatment. It also helps to detect the fractures dislocation combinations, for example, Montegia, and help to ascertain the post-reduction status of fractures with the medico-legal study. So, the role of the X-ray in the case of the fracture is more important to confirm the clinical diagnosis, to study the fracture anatomy, then fracture displacement, to detect the crack and space fracture, to plan the treatment, and to detect the fracture dislocation combination, and to ascertain a post-reduction status of fracture, and also help in medical legal study. So remember the rules in the X-ray. The better the no X-ray than one view X-ray. So one view X-ray is not important. It's better to know X-ray than one view X-ray. X-ray is a shadow. It conceals and distorts. Hence, interpret X-ray with the caution. A joint above and joint below should be included with the fractures under the study. The fracture should be in the middle of the film. The exposure should be adequate and soft tissue shadow should be delineated properly. X-ray should be read by holding the film in an anatomical position. Then proper prospective measures against the radiation should be adopted. Then avoid unnecessary X-ray. Check the X-ray are to be taken without disturbing the plaster cast. So the rules of the X-ray in that there is a better in no X-ray than single view or one view, and X-ray is a shadow. So interpret X-ray with the caution. The joint above and below should be included with the fracture under study. Fracture should be in the middle of the film. Then exposure should be adequate and soft tissue shadow should be delineated properly. So X-ray reading by holding the film is an anatomical position and proper protecting measure against the radiation should be adopted. So avoid unnecessary X-ray and check the X-ray are to be taken without disturbing the plaster cast. So these rules of the X-ray are very important during the practical examination of the orthopedic when X-ray reading is asked by external. And it is very important in the clinical point of view in our clinic hospital when we study the case of the fracture. So always remember the rules in the X-rays. Then CT scan and MRI. These are the most sophisticated investigative methods available now in orthopedics, that is CT scan and MRI. Both are non-invasive and are extremely helpful in detecting both soft tissue and the bone injury. In the more than the X-ray, CT scan and MRI is more sophisticated investigative method as because it is extremely helpful in detecting both soft tissue and bony injuries also. Note, a CT scan is helpful in detecting fracture of the skull, pelvis, spine, and identifying a loose bodies in the joint. An MRI This is useful in diagnose any fracture. So, in addition, it helps to identify soft tissue and ligament injury, and it is certainly the gold standard, but has its Achilles heel in being expensive. So, MRI is a quite expensive diagnosis of any fracture, but it helps to identify a soft tissue and ligament injury. And CT scan helpful in detecting the fracture of the skull, pelvis, spine, and identifying the loose bodies in the jaw. Next is the management of the fractures. The goal of the fracture management is to restore the anatomy back to its normal or as near to normal as possible. The responsibility of orthopedic surgeon is to ensure that there is no functional disability to the patient following the treatment of the fracture. Then, management of the fracture can be broadly classified and discussed under the following head. That is, management of simple fracture, then management of the open fracture, management of the complicated fractures. In that, firstly, when we see the management of the simple fracture is by the conservative and operative method. So then we can use a conservative method for the undisplaced fracture, incomplete fracture and impacted fracture is that A, that is cuff and collar limb for a upper limb fracture. When there is an upper limb fracture, a cuff or and collar sling are useful. Strapping is useful for the fracture of the clavicle, then refracture finger or the toe fracture. Then plaster slab, that is plaster of Paris slab can be used to support the injured limb usually as a first aid measure. When there is an injured limb, POP, that is plaster of Paris slab, is useful as a first aid measure. Then D is a rest and non-steroidal anti-inflammatory drug. That is NSAIDs are useful for the pain relief and to reduce the inflammation. And last is a masterly activity in certain cases like impacted fracture neck of the femur, etc. So when there is a displaced fracture here, the aim is to restore back the normal anatomy of the bone by either close or open direction. So when there is a displacement is seen, so to restore back the normal anatomy of the bone is due to by a close reduction or by the open reduction. So when there is an undisplaced fracture, there is a cuff collar sling, strapping, plaster slab, race, NSAIDs are useful. But when there is a displaced fracture, then there is a close reduction or open reduction is required. So, next point is the management of the fractures by a close reduction. So, what is the close reduction? These consist of resuscitation, reduction, retention, and rehabilitation. So, are important in the management of the fracture by close reduction. Is that first one is a resuscitation. Resuscitation is the topmost priority if the patient is in shock following a fracture. A2F management proposed by McMurphy is to be followed in all the situations of emergencies. Reduction of the fractured fragment if it is displaced, and usually it is done under the general anesthesia, that is GA, and after adequate radiographic study. So when there is a reduction of the fracture fragment if it is displaced, when the fracture fragment is displaced, it is done under the general anesthesia, that is GA, and after a adequate radiographic study. Then reduction methods are close reduction, that it is adopted usually for a simple fracture. Then a technique followed is the traction and counter traction method, and it is a blind technique and need a considerable skill and expertise. So it is commonly result in a mal union. Then close reduction is what? It is adapted usually in simple fracture. When there is a simple fracture, then close reduction is useful. So it is followed in a traction and counter traction method. This is a blind technique. Remember that close reduction is helpful clinically when there is a displaced fracture, a simple fracture. It is a traction and the counter traction mentioned method when blind techniques and need a considerable skill and expertise. So it is commonly results in a malunion. So it is a very difficult, so it needs a skill and expertise. Then a continuous traction. Gen- Certain examples where continuous traction can be used for reduction of fractures are gallows traction for a fracture shaft femur in children, and balanced skeletal traction for adult shaft femur fracture, etc. So continuous traction is useful in a children when there is a fracture of the shaft of the femur, and in adult when there is a femur shaft fracture for balanced skeletal traction. Then the open reduction. So it is done when the